And so we're going to talk about money. And the truth is that Britain has an extraordinarily efficient healthcare system compared with many similarly rich countries. But we always need to think, of course, how we're going to do it better. And the Efficiency Summit at Expo brings together for the first time an expert panel to explain how NHS England's RightCare programme and NHS Improvement's Getting It Right First Time programme are working with all local health economies to deliver better care and better value through reducing variation. A panel are Professor Sir Muir Gray, founder of NHS RightCare, MD of Better Value Healthcare, Professor Matthew Cripps, National Director NHS RightCare, Professor Tim Briggs, Chair of Getting It Right First Time, Henry Black, who's CFO of North East London STP, and Celia Ingham-Clarke, Medical Director for Clinical Effectiveness at NHS England. Each one is going to do a short presentation, a talk. Then we're going to ask for questions from the floor and as much interaction as possible, because there can be no more pressing need than to discuss efficiency and how to do what we do better. Thank you. Muir.
I've had 45 years in NHS and 23 reorganisations of the structure, most of which have made no difference at all. There's been two big ones. 74 brought us all together. 87 drove us all apart, and Lansley aggravated that. So, we're now in a new era, new demands. And what I see happening is very welcome trends, because we recognise that structure really doesn't matter. What does matter is culture, the culture of the NHS. And we'll hear today about two aspects of culture. One is the collaborative culture, working together, and the second is the culture of stewardship. Everyone feeling responsible for the stewardship of resources. And we say to clinicians, if we screw up the NHS, there won't be one in 20 years' time. That's what stewardship's all about. The systems are starting to think across the whole piece, from prevention to long-term care. Now, when we start to look ahead, we can see in the past we had commissioners and providers, and we still have the RightCare programme focused primarily on commissioners, and the GIRFT programme focused primarily on providers and clinicians. But that's the artificial distinction. I want you to think of a spectrum, So if we take the value proposition, we think a spectrum of value. And we developed the concept of triple value. Allocative value, have we allocated the money optimally to different groups, to cancer or mental health or musculoskeletal? Technical value, are we using the money properly? And that's more than efficiency, because it also means, are we seeing the right people? When we look at the variation in the atlas of variation, in some places, we're over-treating people, and in other places, we're not seeing the right people. Usually, it's poor people that we're not seeing. Poor people get less joint replacement than wealthy people. That's not the right way to use the resources. And then there's personalised value. Now, at the commissioner end, it's very clear that the commissioners have to decide how much for musculoskeletal, how much for respiratory, how much for children, how much for old people. At the clinical end, it's very clear the clinician's job is to help the individual patient make the decision that's right for them. But in the middle, there are all sorts of fascinating decisions being made about, for example, how much resource do we put into asthma or bronchitis or sleep apnea. And that's where clinicians, providers, and commissioners come together. So this workshop that you're attending is about value. Value is more than efficiency. And it's a really great platform because you're going to hear from four perspectives. From the NHS England perspective, and then at the local population perspective from an STP, but then the two projects that started necessarily in the commissioner end and in the provider end, RightCare and GIRFT, but are now part of a spectrum. So we'll start with Celia Ingham-Clarke from NHS England. And Celia is a surgeon, but she exemplifies the fact that most of the people who manage resources are clinicians, and as my old director of finance said, it's the docs who spend the money. Celia, over to you.
Just lost 10 quid. Thank you very much, Muir. Good afternoon. So I was asked to talk about what efficiency means for me as a clinician and as a leader in NHS England. And basically, the practical thing is it's about doing the same, or preferably more, better quality for the same or less money. But I think it's also important to consider the impact of efficiency on people. First of all, on staff, because staff tell us they're really, really busy with managing many competing priorities. And also patients. They have better things to do, usually, than sit waiting to be seen in clinic or sit waiting on the ward for the consultant's ward round. So it's about not wasting people's time. My background is as a surgeon, and then as a trust medical director, and then I had a regional lead on quality and a national role on transforming inpatient care. And so I've had an opportunity to see initially hospital surgery in terms of efficiency, and then to spread to a much wider arena. And as a clinician, all the way through my career, I saw resource limitations. Not enough outpatient slots, not long enough outpatient slots, not enough theatre slots, not enough beds, and the impact not just of not enough beds in your own hospital, but in other hospitals when you're trying to make an emergency transfer happen. And those problems are still happening today. So what are the opportunities? Well, first of all, in terms of clinics, GPs now have the opportunity to access consultant advice remotely where appropriate, rather than necessarily sending a patient in. And our early work looks as if that's likely to be more efficient and save costs. There's also the opportunity to shift some clinics into the community, have them led by nurse specialists with backup by an expert consultant behind that. For example, Partha Carr, the diabetologist who works with us, who's done that in his own practice in the south of England. And you can also run virtual follow-up clinics, and we have some early work on virtual fracture clinics, which is looking very promising. What about theatres? Well, in my own trust, we found that we had late theatre starts and long delays between cases, and we dealt with that by building an admissions area right next door to the operating theatres, so the inpatient nurses didn't have to be involved with patients until after their procedure. We didn't need porters, patients could walk to theatre, and it made it much smoother. Also, as GIRFT recommends, if you ring-fence your elective beds, whether in the day surgery unit or on an inpatient basis, or have a standalone elective unit like the South West London Orthopaedic Centre, that gives you the opportunity to protect those beds and to use them more efficiently. Coming on to beds, we know that every winter we double the number of respiratory acute admissions to hospital. But not every hospital doubles the number of respiratory wards in winter. Instead, they leave those respiratory patients as outliers on all sorts of other wards. First of all, that blocks the surgical beds and prevents elective operations. Secondly, it's really inefficient. Doctors talk about doing safari ward rounds, and it's really bad for patients as well, because they don't get seen by the right specialist nurses and the right physiotherapists. They have poorer care, worse outcomes, and longer length of stay. So creating an extra respiratory ward in the winter is well worth doing. We know that, but not everybody does it yet. And then on the surgical side, we know now that for emergency general surgery, if you put a consultant at the front to see and assess the patients, you can reduce the number of emergency admissions for assessment significantly, and you can set up systems such as emergency day case surgery for abscesses, so that instead of a patient traditionally having to be admitted to hospital and wait 1 or 2 nights for that 15-minute slot in theatre when nobody else wants it, and starve for most of that time, the patient with a superficial abscess can be sent home and brought back just for a day case procedure. What about staff? Well, being efficient for staff, first of all, is getting rid of those long outlier ward rounds. Secondly is the idea of that admissions unit next to theatre, so the anaesthetists don't have to go all over the hospital hunting for where the elective patients have been admitted. And many of you will have seen the TV programme from St Mary's Hospital recently, where there was a whole theatre team with surgeon, anaesthetist, nurses and so on set up to do a major elective case. And they all had to be stood down on the day because there was no bed for that patient to be admitted to. That's really inefficient. What about patient flow efficiency? Well, first of all, emergency admissions are still typically clerked repeatedly during the admission process. Being clerked once properly ought to be enough. And if you've got access to the primary care medical record, you can pull a lot of data from that rather than having to gain that information from scratch from the patient or their carers. Also, of course, there's the issue of the patient who's awaiting the consultant ward round for a decision on what happens next in their pathway. And many of you, particularly in relation to your own family members, will be aware of situations where that happens at a weekend and your family member is sitting waiting till Monday for the consultant ward round before the next part of their pathway happens. So there's lots of scope for improvement, and we can do something about this jointly. So for me, efficiency is about doing more for the same or less money while maintaining or preferably improving the quality of care. And it's also about not wasting people's valuable time, and that's staff and patients. Thank you.
Since 1987, we've isolated hospitals from the populations they serve. And we've isolated hospitals from one another by the competition. So hospitals have become institutionalized. The staff have become institutionalized. When I first met Tim Briggs, he was going into hospitals who all thought they were doing a great job, and he was pointing out that maybe they weren't when they compared themselves with others. That did not greatly increase his popularity among everyone who was there, but he was doing the right thing. Since then, when he was, I think, president of the British Orthopaedic Association, he's been given responsibility for the whole span of hospital services to overcome the isolation and institutionalization, to make people look at their services. And it's called Getting It Right First Time. Tim, over to you.
Fantastic. Thank you very much indeed, Muir, and thank you for inviting me. And really, I'm going to present to you what I really want to get out of the Getting It Right First Time as we move forward in the NHS over the next few years. It's about improving the quality of care we deliver to patients, reduce unwanted variation and complications. It came from orthopaedics, because I'm an orthopaedic surgeon, and I was also medical director at the RNOH and could see in 2010 that we were going to have to do things differently if we're going to manage to provide ongoing high quality care for our patients. And it's all about improving the quality we deliver by re-empowering our clinicians, and from that we would get better outcomes, squeeze out the unwanted variation, and from that we would get significant savings. What we did in orthopaedics on an elective side was to collect 12 sets of data, you can see it there in front of you, including litigation data, and get that into a report that we could send to each trust. Once they had that report, we went to visit them, and over the last 2 years I've visited every single hospital in England, Wales, Scotland, and Northern Ireland, and we have found significant variation. So what did the pilot tell us, and what can we do about it? In orthopaedics, there was huge variation in practice and outcomes in terms of clinical costs, infection rates, readmission rates, and litigation rates, but there is no doubt that there is scope out there to tackle many of these variations. And actually what I found visiting most hospitals is that many of the answers actually are already out there. Here on the slide on the left is patients who are over 60, who have an arthroscopy of the knee and then have a knee replacement within a year. All those red blobs are outliers, and we found some trusts, 20% of patients were having that sort of intervention, which we could say is a waste of time, and you'd be correct. Now when we go back out there, we see a huge change in practice with now arthroscopy rates as low as 3%, and just moving that one metrics is saving the NHS £1 million every 2 months. This is a trust we went to at St Helens and Knowlesy, talking about what they're paying for their prostheses of hip and knee replacement, and look at the savings they've made in 1 year just on hearing the data about what other people are paying for implants. And what we found across the piece, just by showing that data on the GIRFT pilot, was that we've seen a significant reduction in length of stay for hip and knee replacement, use of appropriate implants in the elderly age group, ring-fence beds, as Celia said, to increase your productivity and reduce your infection rates, and other aspects that have seen 45 to 50 million pounds of savings over 2 years just by scratching the surface and a result of improved quality of care. One thing that we've also seen is by showing litigation data, and that's been a topic in the press over the last 2 weeks, is that when we started our GIRFT visits, we saw an increase in the number of litigation claims in elective orthopaedics. But in the last 2014-15 and 2015-16, we've seen a 5% and an 8% drop in the absolute number of claims by just showing the data and asking trusts to look at their litigation orthopaedics and act upon it. And that again has saved about 45 to 50 million pounds by improving quality. Now, what is going to drive the change is data. And by December of this year, we'll have 270 metrics for orthopaedics for every single trust in our data warehouse, which will be accessible through the Model Hospital portal. And as we ramp up the GIRFT programme now, we got a grant of £60 million to the Secretary of State in November last year. We're now going to look at 34 specialties, and we have 18 clinical work streams out there, and there have been over 800 individual hospital visits by these national leads that we've appointed, and we will see significant change as a result in practice. So I don't know if any of you have seen, but the General Surgical National Report was published on the 4th of August 2017, and let me tell you, it is a game changer for NHS providers. There is an urgent need, I think, for all of us to address unwanted variation, and it will change practice, and it will be evidence-based. For instance, 80% of general surgeons do not know their infection rates. And if you could have a general surgeon as a senior decision maker behind the front door of A&E, you can reduce your hospital admission rate by 30%. Do we have examples where that has been achieved? Absolutely right. Nottingham's a very good example, and Fife in Scotland another. Again, in general surgery, you can see there, again, on the left-hand side, is patients who have an elective colorectal operation. The best length of stay is 5.5 days. The average is 10.2 days. Why is there such variation? And on the right-hand side, those blobs represent each is a trust in England, and your readmission rate after a cholecystectomy, where your gallbladder is removed, can vary from 0 to 12%. And we've got to understand why that is the case. So between September and January, we had the general surgical report. We're going to have a national vascular report, surgical litigation report, neurosurgery, urology, and spinal national report. And by December 2018, we'll have data sets available on, it's going backwards, I'm sorry about this. We'll have data sets available on 34 specialties. Guys, can you do something about that? It's going backwards. It's doing itself.
Just go for it, Tim.
Yeah. So we'll have data sets available by December 18 on all 34 specialties, which will give us between 6,500 and 10,000 individual metrics on every single trust. And we're going to let trusts look at their data, and then when we're happy with it, we're going to let trusts look at everybody else's data. This is an example in surgical specialties litigation. I don't want you to look at the numbers, but just look at the graphs and the variation, and it doesn't matter which specialty you look at, it's something that we've got to understand because we've got to reduce the litigation costs across providers. And I hope that this will stimulate the debate amongst individual trusts to improve their litigation. And what happens is all this data will sit behind the model hospital, which is part of NHSI. You'll access it through there, and then you go into the portal, so you'll be able to access by December 2018, as I said, between 6,500 and 10,000 data sets. So, will it deliver? Well, the King's Fund did a report, which was published in June of 2017, and they think GIRFT has huge potential to drive the change. Why? It's data-driven, peer-to-peer review by clinicians, it's non-confrontational, highlights where clinicians are doing good work, and highlights where they need to improve. And I think what's great about this programme is it's got the support of absolutely everybody, from politicians, arm-length bodies, clinicians, rural colleges, and everybody. So the next steps are 34 specialty visits to all trusts. We need to know what does good look like. We'll implement the solutions from the national reports over the next 3 years, and what we'll be using is clinical evidence to drive the change and behaviour. And it will mean different ways of working, and it will provide the clinical evidence at both local trust level, network and STP level to drive the change, and will mean, I think, some centralisation of services, We'll have to develop hot and cold sites and ring-fence beds, as Celia has just alluded to, and it will result, I believe, in high quality care and also best value. Thank you very much.
Well, there's one thing I really disagree with you. It's not data, it's leadership. And you're giving great leadership, Tim, to the programme. It's words that change the world, not numbers. So Tim's really bringing about a big change there. And the introduction to the next session, just like to say, one of my favourite songs is by the Everly Brothers, Bye Bye Love, Hello Loneliness. Any of you remember the Everly Brothers? I may be too old. Because this is the BMJ this week. Farewell CCGs, hello ACSs. And we're now seeing a shift to this idea of population-based systems, and Simon's chosen the name accountable care systems. And the midwives, or the transformers, are going to be the STPs. And Henry Black's going to give us an insight from the STPs about this process of transformation without structural reorganisation. Henry, over to you.
Thank you. Thank you very much. Good afternoon, everyone. It's a great pleasure to be here. My name's Henry Black. In my day job, I'm the CFO for Tower Hamlets CCG. But for the last 18 months or so, I have been the lead CFO for North East London STP. We've heard from some of the eminent national leaders in some of the techniques that we are using to drive out variation. But I've been asked to give a bit of a flavour and a reflection as to how this is kind of being translated into implementation, if you like, in terms of local STPs taking some of these things forward. So I'll talk through our approach that we are driving in North East London, our single financial strategy, the governance and committee structures and processes that we've put in place to try to support that collaboration, and then give a couple of brief examples as to some of the work that we're doing to take the agenda forward. So a quick overview of North East London. This is our STP footprint. The first thing to say is that we've undergone a bit of a rebranding exercise recently, moving away from the STP acronym. The NHS loves a bit of a pointless rebranding exercise, but in this instance, there is a point to it. I think moving the STPs were brought in as part of the planning guidance, and we don't collectively consider ourselves 20 organisations working in collaboration to be a plan. We're a partnership. So the STP acronym doesn't quite fit anymore. Also, it's generally seen as a health construct, and it's important to ensure that local authority partners are equally at the table, and to be able to generate a kind of bottom-up and authentic sense of identity to a partnership. It's important to create that kind of identity. The geographical area that we cover is, I suppose, in kind of national context, it's not a large size geographically, but in terms of population, it's a big population. Oh, the slides have got doing their own thing. So we have best part of 2 million population. We've got huge diversity, both in terms of culture, but also in terms of health outcomes. So one of the things that we're here today to talk about is how to identify and then drive out variation in care and variation in outcomes. So it strikes me that a crucial way of doing this is to extend the kind of scope of management where strategically sensible, so that different organisations within one geographical area can compare one against the other, and use benchmarking techniques like GIRFT and RightCare to deliver better care for the whole population. Some of our wicked issues. As I said, we have huge diversity. We've got some of the richest parts of the country. We have the City of London with the banking district and the square mile. And we have the Canary Wharf, which has a large density of wealthy population. And then living cheek by jowl, we have some of the most deprived populations in the country. So we have inner city Hackney and Newham and Dagenham, amongst others, all with very different populations and different needs. So I said I would talk about our single financial strategy. So this is a kind of fairly, we're breaking new ground in terms of the kind of comfort zone of, and which Muir kind of referred to before, about how organisations now need to come together to collectively deliver system financial balance. So we have a single financial strategy. The sovereign organisations obviously retain their own statutory responsibility for delivering their own objectives, but the ability to be able to see and reflect on how certain, if you like, traditional contracting behaviours impact on one another is a very useful exercise, and genuine demand management and cost control. I think we've all proven to ourselves that those objectives can't really be delivered by organisations working in isolation. In addition to that, we have a lot of work on a new payment model, which I'll talk a bit more about in a minute, and a risk share mechanism that supports the ability for providers to be able to work collectively. So a bit about our governance and sort of committee structures, if you like. These are the new and different ways of working that we've introduced to move away from traditional adversarial contracting and try to work in collaboration and deliver common goals. So we have our Financial Strategy Committee owns the single financial strategy, very high-level, tight group. We then have what we know as the Operational Delivery Group, which was very successful last year in delivering a single plan, all of the partners working together with their own operating plan timetables and statutory requirements, but alongside that, a single plan that clearly identified where there is potential for one organisation's plans to have a detrimental impact on another's. We have a control total monitoring tool, which for the first time gives us a reporting mechanism that flushes out where contractual differences are clearly the case, where providers are expecting in their plans more income than commissioners are expecting to spend, and that's a very useful piece of it's transparent reporting that we've never had before. All of this is supported by 3 system delivery boards, which are operational in focus. Those are the local system-level forums for clinicians, ops people, and transformation program managers, instead of working in their own little silos, all coming together to use the RightCare and the GIRFT techniques to deliver a single plan. I'm getting the nod. So a very quick overview of 2 pieces of work that we're doing. Using the GIRFT principles, we're doing a site optimization review on 3 of our biggest sites. They're not currently configured in the way that one would hope optimally they would be. A large PFI site, a smaller DGH, and a mental health inpatient facility. And clearly the opportunities for applying GIRFT principles to ensure that the right things happen in the right place, rather than just where the organisations have allowed them to emerge through clinical and operational features. That's a key benefit from collaborative working. And finally, payment reform. So we have a huge consultation exercise across all 20 partners, including health and wellbeing boards, health watches, and the like, trying to design a new payment system that's capable of delivering accountable care and supporting outcomes rather than payment by activity measures and the old traditional ways of working. But I've run out of time, so I'll leave it there.
Our final speaker is the yin to the yang of GIRFT, Matthew Cripps. Matthew Cripps was a classic scholar, so he brings both the Greek philosophers and Julius Caesar. Julius Caesar is very handy when it comes to dealing with the NHS. He brings this different approach. And he, like Tim, has had to take a leadership role of working with top management and finance colleagues, because Matthew's also finance qualified, to make them think not just about balancing the books and seeing what they can load onto some other budget, but to think about value. So Matthew is the director of the RightCare program. Matthew, please.
Thank you, Muir. I was going to apologise if I come across as melancholy, but I've just lost a £10 bet to Muir. But actually, I find myself quite cheered by the experience. So we were outside earlier, and he claimed he was going to stick to 4 minutes in his introductory speech. And I guffawed on the basis that he's never stuck to time in any speech in his life. And he offered me the bet, and I thought, well, this is easy money, so I took it. And then he kept within, I think it was 3 minutes, 48 seconds. So I was feeling a bit low while everyone else was talking. And then I realised I've actually practiced what RightCare preaches. I've invested to save, because I've discovered something that no one else previously knew, which is that you can keep Muir to time by way of a financial incentive. Anyway, you've heard from people far more expert than me on the clinical aspects, so I thought I would just give you a few examples of real financial efficiency being delivered via population healthcare improvement to demonstrate that this really can and does work. So Blackpool CCG adopted the RightCare approach before it was mandated by NHS England, and they reduced frequent calls amongst the top 50 callers by 89%, and A&E attends by 93%, and admissions by 82%, saving £2 million. Population healthcare improvement that drives financial efficiency. This work was the prototype for our high-impact intervention work on high-intensity users and is now in dozens of other local health economies having the same and similar impact. Bradford CCGs, they focused via their RightCare lens on CVD and stroke and reduced deaths by stroke and MI by 210 in the first year of impact, saving at least £1.6 million. And that's the prototype for our CVD prevention optimal pathway that you can all get from our website. Slough, via their complex case management innovations, when they adopted the RightCare approach, reduced A&E demand by 24% and non-elective admissions by 17% in the target population. The percentage drop in associated spend is greater than that because this impact is all at the most complex, more expensive end. The RightCare rollout began last year, and the first third of local health economies adopted it and had part-year effect last year. And the early evaluation from that part-year effect is beginning to come through and is showing shifts, such as in respiratory, where across those CCGs, they've moved from a 6.7% growth in respiratory activity to a 7% reduction, and a similar shift in spend. And in GU activity has stopped going up, was going up at 3.8% and is beginning to come down, is coming down at 10.9%. The financial impact of that activity shift is it's gone from an 11% growth to an 8% reduction, and so on, and so on. And it would be remiss of me, as a former finance director, and driving this programme forwards with my team, not to make the point that the RightCare approach is built on the foundations of optimal financial management. It's built on the principles and teachings of the Chartered Institute of Public Finance Accountants and on the work of CIMA as well. And our work on value is built into CIMA's global management accounting principles. So if there's anyone here who's CIMA qualified, you're actually professionally obliged to follow the RightCare approach. Thank you very much.
So before I pass over to our distinguished facilitator, Gavin Esler, what I'd like to do is to turn to your neighbour, introduce yourself, and we'll give you 2 minutes to think about how this will change what you do when you go back after the conference, and then we've got time for question and discussion. Okay, 2 minutes discussion, starting now.
5, 4, 3,
2, 1, stop. You must stop talking. You must stop talking. Carol, must stop talking. Okay, Gavin, over to you.
Thanks very much, Muir. I've learned a lot in the past hour, including not to make a bet with Muir. But let's have some questions. What's on your mind? Yes, gentleman down there. We'll get a microphone to you. Can we? Yes, lady there in white. Gentleman at the front for a microphone. Do we have microphones? Is there anybody over this side while we're waiting? Is there a lady over there with a microphone? Nope. Yeah, is there anybody on this side who'd like to answer a question? I'll come back to you, sir. I just, yes, there's a gentleman in the middle. Can we move to the gentleman in the middle, please? Thank you. And then have that gentleman next.
Yeah.
Hi, my name is Matthew Atkinson. I'm a public health doctor. And I'm wondering, do you think we'll get to the point where acute hospitals feel responsible for the care of their entire population? And if so, do you think that will be because of financial incentives or because of a cultural shift?
Who'd like, Tim, perhaps? Who'd like to take that?
That's a very good question, I have to say. I think that the first thing we've got to do in the provider side, and the way I look at it, if you look at London as an example, we spend $1 billion a year on primary care, $2 billion on mental health, and then $13 billion on the provider side. So what we're trying to do with GIRFT at the moment is trying to get the provider side, so where we squeeze out all the unwanted variation, complications, and improve care, make sure that we get best value. We link in very much with RightCare, so we look at across the whole pathway of care to try and make sure that all the patient populations and patients therefore flow through the system as effectively and efficiently as we can, getting the right outcome. And then what you're asking really is there going to be a blurring, if you like, between primary and secondary care? I think primary care is changing, although I work in the secondary care sector, and I wouldn't want to second guess that, but I think there will be much more a coming together of the whole pathway with time to make sure we get best value and best outcome. I personally think that will happen.
How many people in the audience from hospital management? Any hands up, the hospital management? My question to the chief, and you can try this, this is sales. My question to the hospital chief executive is, are you in the real estate business or the knowledge business? Now, some of them look very baffled about that. But the president of Toyota said Toyota is a knowledge company. You have to know about things, about plastic, steel, competitors in the future. So I think it's up to us, up to public health, not to try to persuade them with the word public health, because they don't like that. But ask them, are they in the real estate business or the knowledge business? It will inevitably happen, and the work Tim's doing and the work of RightCare, we're going to blur that completely. We're going to go back to a collaborative way of working. So that will happen.
Thank you. Gentleman there.
Good morning, or good afternoon. My name's David Cartwright. I'm a patient, amongst other things. I quite agree with what the surgeon said about people waiting to go to theatres and then being told after waiting 8-9 hours that there's no bed for them to go to after they've had the surgery, and therefore they have to wait. My question is very simple. To all the panel, how, on a piece of A5 paper, will you explain to the communities, to the people that want the services, how are they going to access them, and where are they going to get the best results?
Celia?
Well, we give information for patients and the public through the NHS Choices website. So if you want to find out about any particular service, that's the place to look. But we know the sorts of numbers that make a difference in terms of cancelled operations. So if hospitals are full above 85%, it then becomes really difficult to run them efficiently. And so that's one of the things that's monitored now, is the level of bed occupancy. And having cut beds for years and years and years and years, hospitals are now beginning to increase them again a bit, which is the right thing to do, notwithstanding the financial situation that we're in, because it is so inefficient to do things like cancelling people on the day.
Henry, would you like to come in on that?
Yeah. Sorry, is it on? It's interesting. many of the issues that create the situation that you describe are within our control, but they're just not necessarily within the control of one organisation working on their own. And I think that's the key thing about STPs create the kind of environment and the conditions in which collaboration and accountable care can be delivered. But what it really needs is a step change for organisations who do look after patients along a pathway and do work in a system that whether they like it or not is not a set of individual isolated kind of units, but is one system that needs to work as one system and needs to operate in a way that prevents those unnecessary cancellations from happening, whether it's through better, more flexible bed management or a better aligned care management, or through partners working together to ensure that discharges happen when they're meant to, so these cancellations don't take place.
Thank you. Some more thoughts? Anybody else? We've got just a couple more minutes left.
There's one over there.
Yes, gentleman at the front and then gentleman behind.
I wanted to ask you a bit about when you find these efficiencies in secondary care. One of the challenges that I think lots of us are facing at the moment is how we then get that money to flow to other areas of our system to support them in working in different ways. And I think there's a lot of talk about more money in primary care and growing our primary care services. What are your thoughts on the steps we should be taking to get that money to move?
Matthew.
So we like inventing acronyms in RightCare, and our latest one is called CROC, which stands for the Coordinated Reallocation of Capacity, which is exactly that agenda. There is, and it comes back to the question previously, beds, diagnostic tests, outpatient clinics, a lot of the stuff in secondary care, a significant proportion of it is the manifestation of unwarranted variation. And delivering or eradicating that unwarranted variation involves putting more stuff in the other bits of the system prior to secondary care. And the coordinated reallocation of capacity is an attempt, and it's going to happen at STP level with CCGs and providers driving it, to take the resources that are around that capacity that's being used